My name is Robert Kutzner. I'm a pain specialist, anesthesia background, intensive care, and I'm also interventional, old guy. So now I'm just got a little pain clinic, and work with multidisciplinary approach. Anyway, my practice, yes, I see the addicts come and go, but there's ways to address that. One is cures, which is a great program, guys. Maybe you run a little bit behind, 1 month, 2 months. Sometime you'll get, take care of that. But specifically, when I am dealing with an addicted patient, somebody that's drug seeking or they have a lot of drugs, I don't deny that they might have pain. Obviously, addicts can have pain too. I take advantage of the opportunity to treat them. I got them now. Okay? And we try to do at that time cures and pain agreements, etc. One of the things I do is old school, been around forever. I'd like someone here to comment on it because I don't see it in practice too much. There's a few people that do it mostly at the university level, but that's a blind pain cocktail. It's very hard to snort up cherry syrup or shoot it up, etc. And it works very well. It's been around since Egyptian times. Would you comment on that, please?
I think blind pain cocktail is a great way to supplement a detox. But one of the things that we learn is that detox and treating an addict is not it's not a monodisciplinary field. You need help. You can't do it all on your own, especially those of us of anesthesia background.
Yeah, let me interrupt for just a second because I have a Suboxone license and all that stuff. I don't detox patients. I got a clinic, and I'm treating pain. So it's not a detox issue. It's an issue of controlling diversion.
Well, it's also an issue of opiate reduction. I don't think it's really possible. It's very difficult to assess a patient's pain when they're on large doses of opiates, especially if they're walking in the door on large doses of opiates. You have no idea what their baseline is. And it may be that they're hyperalgesic. It may be that the opiates have accelerated their complaints of pain. And so you really do need to do some kind of opiate reduction. And whether you want to call it detox or opiate reduction really doesn't matter. And a blind pain cocktail is a really good way of doing that if you've got a cooperative pharmacy and a cooperative patient, and you've got the whole thing set up.
Okay, so why, you pharmacists and you physicians, why aren't we turning to that for these minority of cases?
I don't know what that is.
A blind pain cocktail, you come to me and you're taking, 100 milligrams of morphine a day, equivalents of hydrocodone. I give you 60 milligrams in morphine or some narcotic in cherry syrup. You get your little flask, lasts for 2 weeks. I'll probably put hydroxyzine in it and acetaminophen, something like that. You agree that you will not know what's in there. If you want to know, just ask me. I'll tell you, or ask the pharmacy, I'll tell you. But then, boom, you're done. If you do that, then I take every 2 weeks and I cut back the narcotics. I have one patient now, I've had many in the past, will end up on cherry syrup, and I end up having to tell them, hey, we're doing good now, you can just get off the stuff. Okay. So you're right, it works very good. I'm just flabbergasted that with all the people that are dying and stuff, all these things going on, I know that Dr. Mackey at Stanford does it, I know a lot of people who do it. Why aren't we doing it? Why isn't it being promoted?